Namaskar, all the respected delegates. So today, generally, we had made in the occasion, a holy occasion of Swami Vivekananda Jayanti, and we are going to discuss on a very important topic, though it is very a neglected one in medical field, as it is also a neglected tropical disease, that is leprosy. So I welcome you all on behalf of Bengal Forum of Clinical Pharmacology and Therapeutics and Inuvo Care Health Solution in this webinar. And to start this webinar, I just want to recite one of the most favorite slokas of Swami Vivekananda, that is from Nirvanashtakam, few lines from that Nirvanashtakam. न मे देश रागो न मे लोभ मोह मदो नैव मे नैव मात्सर्य भाव न धर्मो न चार्थो न कामो न मोक्ष चिदानंद रूप शिवोहम शिवोहम न पुण्यं न पापं न सौख्यं न दुःखं न मंत्रो न तीर्थ न वेदा न यज्ञ अहम भोजनं नैव अहम भोजनं नैव भोज्यं न भोक्ता चिदानंद रूप शिवोहम शिवोहम. So Swamiji had translated this in a very simple way, that is, I have neither aversion nor attachment, neither greed nor delusion, neither egotism nor envy, neither dharma nor moksha. I am neither desire nor objects of desire. I am existence absolute, knowledge absolute, and bliss absolute. I am Shiva, I am Shiva. Shivoham, Shivoham. And the second stanza is again very important. That is, I am neither sin nor virtue, neither pleasure nor pain, nor temple nor worship, nor pilgrimage, nor scriptures, neither the act of enjoying the enjoyable nor the enjoyer. So this is very interesting. Neither the act of enjoying the enjoyable nor the enjoyer. I am existence absolute, knowledge absolute, bliss absolute. I am he, Shivoham, Shivoham. So Swami Vivekananda generally taught us regarding the renunciation and service. So which were the twin glowing ideals that he had placed before Indians. And these are one of the important principles while we are going to treat our patients, specifically the leprosy patients. He had told that infinite patience, infinite purity, infinite perseverance are the secret of success in a good cause. And for that, he had told us, arise, awake, and stop not till the goal is reached. So this is a very important message regarding the leprosy management also. And for that, we are really fortunate that we had today with us some great persons who contributed their life towards these leprosy patients. So we have Dr. V.M. Katoj, who is a formerly DG ICMR, and he was an ex-president of JIPMAR, Pondicherry also. The most important is that he had dedicated his life towards managing leprosy patients. And with him to chair this session, we have Professor Shantanu Kumar Tripathi sir, who is a senior clinical pharmacologist, and he had chaired different national regulatory bodies regarding the drug related matters. So I welcome Professor V.M. Katoj sir and Professor Shantanu Kumar Tripathi sir to chair this webinar. And we have Dr. Kiran Katoj, who generally needs no introduction in the field of leprosy. she had contributed a lot, not only managing the leprosy patients, she had a lot of contributions regarding the research related to leprosy. So we are really fortunate to have Madam with us. Welcome you, Professor Kiran Katoch, Madam, in this webinar. And we have also the President of Indian Association of Leprologists, and who is a very well-known dermatologist in India. He is also an international figure in the field of dermatology. So that is Professor Rothindranath Dotto, sir. Welcome you, sir, in this August gathering. So now I am requesting our chairperson, sirs, to have their important notes, and so that we can start the session. Over to you, sir.
Thank you, Dr. Shambho Samajdar. I'll request Dr. Tripathi to make the initial remarks. I think that's it. I'll request him. Yes.
So thank you very much, sir. Thank you, Dr. Shambho. What could be a better way of remembering Swamiji on this auspicious day of Swamiji Jayanti? And particularly, again, the best way probably to remember Swamiji is his devotion for the downtrodden, for the weaker sections of the society, and he has always upheld, Swamiji has always upheld the self-dignity, and he has said that every human being actually is harboring the God. So when this is reminded to us, we also are reminded our commitment to a distressing soul, okay, and it's our obligation, social obligation. We'll try to actually take stock of things, what we have, to what extent we have actually achieved, if at all we have achieved in the field of leprosy care through decades and decades, and where do we stand today and how to go forward. And we are really fortunate to have amongst us today people like Professor V.M. Katoch, Dr. K. Katoch, Professor Arindatta, and none other than Dr. Shambho himself, who is very young and enthusiastic. And I hope that it will be really a great opportunity for all of us to be blessed with, or to get this opportunity to learn, and through learn together, learn from each other, and finally this learning would actually help us in getting to the goal of providing care to the people who are suffering from leprosy, and also towards the final goal of a leprosy-free world. With these few words, I hand over to our respected Professor B.M. Katoch to formally inaugurate the sessions. And the first, I think, Professor K. Katoch should be speaking on the public health perspective of leprosy, followed by, I think, Dr. Professor Datta, who is a renowned dermatologist of the country. He will be speaking the dermatologist perspective, and then finally the promise of vaccine in the field of leprosy, that is MIP, which is again a matter of pride for us Indians, and because it has been indigenously developed by none other than Professor Talwar, and Dr. Shambho is going to talk about that MIP vaccine. I now hand over to Professor V.M. Katoch, sir, please. Professor Katoch, thank you.
Thank you very much, Professor Tripathi Sahab. I think this occasion, which I think is a gift of Professor Tripathi to us actually this evening, and great pleasure to welcome our own president, Professor Arindatta, and Of course, I saw a number of other leprologists joining. Dr. I think Hemant Kar was again supposed to join. He told he will joining. I saw Dr. Ivankar joining. And there may be others, which I may not have seen, but I welcome all of them. See, there's such a kind of intellectual, I think, the bent of mind which Dr. Shantanu Tripathi has shown, of course, with the all support of our president, Dr. Arundatta. And the last, actually mid-term, the first annual symposium was organized, which again, brought many young people like Dr. Shambhu to our fold. But Dr. Tripathi, of course, has been a known person as a pharmacologist for leishmaniasis and leprosy everywhere. But then, we got the people like him. We got so many people other from the Bengal medical colleges, other places. That showed the flair for intellectual growth, I think, which is something very nicely exhibited by Dr. Tripathi. On this occasion, the occasion to pay tribute to, I think, among the greatest Indians, Swami Vivekananda, personally a humanist actually, who showed how the Hinduism encompasses everything. See, the way he won the West, the way he showed to the all people on the world that all religions, they lead to the same way, same place actually, but why they fight? But during his fight, he could connect everybody. So Swami Vivekananda remains, eternally relevant for the people who create conflict among the people on the name of religion, caste, and divisions. In a very short life, he was a very socially conscious person. He looked at the marginalized people, as Dr. Shambhu also talked about. He looked at the issues which were ignored. And in that short span, what the imprint left on the psyche of the people, both India and abroad, I think is unique actually, very, very unique. So he will be an inspiration to everybody, for anybody. I don't say Indian only, I don't say Hindu only, because he brought great pride to Hinduism, the liberal face of Hinduism, encompassing face of the Hinduism. But then he linked it to everybody. His voice, he showed there is a voice of humanism actually, Hinduism and humanism at the best. So I think it's a great day to pay tribute to him. And today, think of, doing something for the specialties where we contributed, and remember him that way, that today we take stock of where we think what should be done to address the remaining issues of leprosy. Number of the people will be there who will be listening. They will have their own ideas. But in this, actually, at least the three people will be there to share their views. Dr. Kiran will be talking on the leprosy, a perennial public health problem, concern in India. Professor Datta will be talking on diagnosis and management of leprosy from the dermatologist perspective. And then, of course, our Shambhu will be talking on the MIP vaccine, the current scenario, current status. And in that way, there will be time to think this 1.5 hour, will be time to think of what best we can do in the today's circumstances and what needs to be done. With these words, first speaker, I'll ask Dr. Kiran Katoch to start her presentation. See, I think I don't think the people who we need to introduce, but the question is, there will be many youngsters others than the traditional leprologists who might have joined. I don't know who are there actually today, but the people like us, people like me, Dr. Kiran, Dr. Datta, we are there for long years actually. In fact, me and Kiran, we joined ICMR together in Jalma together in 79. And it's a long journey. This entire journey in Jalma, the number of colleagues I saw from Jalma also joining. We did our best, but her main sphere has been on the clinical leprosy. Clinical leprosy, looking at the systemic disease, clinical leprosy, looking at the therapeutics, how to modify the regimens, how to create the new regimens. And then that includes both by the chemotherapy and immunotherapy. But her last years actually have been more as a public health person, how to reach out to the masses in the Ghatampur and those areas, which became the National Model Rural Health Research Center. And I think now in 30 states of the union. So that I think her life moved from a clinic to and then institution, then periphery. And that's what that life she spends today. I'll request her to start her presentation. And I think we can start sharing the screen from here.
Mr. Rohan Tripathi is there. He will share the screen.
Okay, good.
So
that
that will be.
that'll be better. Yes. So
Yeah.
please ask him to share the screen.
Yeah,
She'll
yeah.
come. मेरे बीच पे आ जाओ, फिर भी।
ठीक है, ठीक। Thank you, sir. Thank you, everybody, and namaskar, sir. Greetings for Vivekananda Jayanti, sir. And with this and with all of your support, sir, I'll try to put forward some of the views which are there on leprosy, which is supposed to be a neglected disease. So can I have the first slide, please?
Just a moment, ma'am. Just a moment.
Okay, okay, yes, sir. Thank you, sir. So next, please, sir. Next slide, please, sir. Sir, everybody knows what I'm going to speak about, sir. It is actually the perennial public health problem as has been put forward. Sir, but what I would like to say, sir, here was what is the background and what are the challenges that we face so that this does not remain a public health problem and not even a problem at the local level, sir. Yes, we have eliminated leprosy as a public health as a nation, but there are still pockets in several districts and in several states which continue. The level of the disease continues to be a little more than what the elimination level is, as defined by WHO. The main background about this was that this leprosy finds its you can find it in any book from time immemorial, whether it is the Bible, whether it is our scriptures, or even whether it is the Muslim scriptures. Everywhere you'll find mention of leprosy, that this is a dreaded disease and it was believed to be the curse of God. Today, of course, it is no longer believed as a curse of God, and the bacilli was identified and it was correlated with the disease. It was one of the first mycobacteria to be correlated with the disease, but it still remains. Several of the diseases we have overtaken. Several of these we have eradicated, and several have gone much lower than the leprosy level. But this still remains a scourge, and especially in our country. It is not cultivable. The major problem is that it is not cultivable in any artificial media because it has, and because it is believed that the doubling time is too long, and what it requires, what are the pathogenesis and what it requires for its growth and for its dormancy is still not known. So the culture, it cannot be culturable. So you cannot say that this disease has, that you only say it by the clinical science that the disease has subsided or not subsided. Or as now, which is going on is, you have completed the fixed duration therapy. That is why you are cured. That is what it is still defined. So it is still not cultivable in any artificial media. The symptoms and signs, both of the skin and a nerve, are the main things which tell us that the disease is still active. The other organs are also involved, but the other organs, they have a very huge reserve. So symptoms don't arise because of the organ involvement. Although just like COVID, the main symptoms are the respiratory symptoms. Everybody says it is a respiratory disease, but it doesn't mean that it doesn't involve the other organs. We have seen it involves the CNS, it involves the GIT, it involves the kidney, everything it involves. Similarly, because this bacilli also travels in the blood, although it is primarily there in the skin and nerves, but other organs are involved. But because of the reserves, no symptoms arise because of this. Of course, in the earlier days when there was no MDT, there was no treatment, you did find a lot of involvement of the other organs, which included the lymph nodes, the liver, the testicles, the infertility that occurred, and of course the disabilities which is there since the very beginning. The main problem is it has a very long or a variable incubation period. In some people, it manifests very early. In others, it manifests quite late or never manifest in their lifetime, although they have been exposed to the organism. And if you test their blood, they do have anti-leprosy antibodies, but they never suffer from the disease. So we don't know why it manifests in some and why it doesn't manifest in. The main problem with leprosy is that it is associated with disabilities, and these disabilities leads to stigma. Unlike TB, which is also a mycobacterial disease, there is no mortality in this. You cannot per se say that this person died of leprosy. He died of involvement. He was a leprosy patient, but he did not die because of this disease. He died because of organ involvement of some other part of the body and not the skin or the nerve. So that is why we say that this has taken a backstage as compared to other diseases which are more virulent, cause more mortality, and they have taken the center stage. And they are also culturable. You have defined them. But the main problem with leprosy is the stigma associated, because on the long run, disabilities do occur before treatment, after treatment, during treatment, and that leads to a lot of stigma, both self stigma as well as the stigma in the community. This is, next slide please. Next slide please. See, these are just some, the earlier ones, sir. See, I have just brought this out, sir, because I wanted just to show, sir, that leprosy, we do say that leprosy is a disease of skin and nerves, but not necessarily that it is the only thing. They can also present, the patient can also present with lepra reaction. As you see in the left corner here, the patient is presenting with a lepra reaction. The second one is with disability, swelling of the hands. This is also a part of the lepra reaction, or the ENL reaction that you see on the number of nodules on the back as well as on the hands. The patient may present first because of this. So this is where, especially, these goes unrecognized. They are there in the surroundings, with the people, with their contacts, with the environment, and they go on spreading the disease because they shed bacilli. If left untreated, they present with disabilities. As you can see in the lower thing, it can be disabilities of the hand. It can be disabilities of the foot. They cannot lift up the foot. They are also disabilities of the eye, which I have not shown here. And also, because even after they get cured, there is a loss of sensation. So when the patient walks barefooted or gets hurt on his feet, it leads to trophic ulceration, which is also a disability. And with this, the patient, you have noticed that these patients are always bandaged. They always listening because they want to protect their feet and their hands. And women especially, they usually burn their fingers while cooking and others because inadvertently they burn themselves. So these disabilities actually could be the first presenting sign of leprosy, or when the patient realizes that yes, probably he is having leprosy or kushtrog, and he goes to a doctor. Next please. The next set of slides again is, no sir, after this, the one which you showed earlier, sir. One more, sir, earlier one. Anyway, sir, this is what I was just trying to say. Next, sir. Yes, sir. Here, it can be a single patch, sir. A patient may have a single patch. 95% of these patients, they don't require treatment and they self-heal. But we still don't know who will self-heal and who requires treatment. So anybody with the patch, diagnosed with the patch, is given treatment. Once the diagnosis of leprosy is made, they give treatment, sir. You'll see this smiling girl, sir. She just has a patch on the hand, but if you look closely, she also has it on her face. So this is that they have no symptoms except for the patch, sir. There would be a loss of sensation if you examine it, but otherwise it is just this thing. It affects both the sexes, male as well as female, although it is reported more commonly in the males. But now as the females are coming forward for examination and for treatment, the proportion of females is increasing, but still males, it is more common in males. It is curable when optimally treated. I've said optimally, sir, not incompletely or inadequately treated. It is totally curable without any sign or symptoms left behind if they have come early. I already emphasized this very low mortality, but the morbidity is very high, especially in patients who present with disabilities. Then the last picture, which is there on the right-hand side corner, sir, this is of a lepromatous leprosy patient, sir. I didn't want to show the face, but still I had to show because that is how we will say the thickening of the ears. The students, especially when we were students of the medical college, these patients were recognized very nicely. Now, with the decreasing incidence, some of the students may not have ever seen a lepromatous leprosy patient, but it is their loss of eyebrows, thickening of the ears, depression of the nose, and very thick, peculiar type of thickening of the skin. Not like myxedema, but it is a thickened skin and a very rough skin with loss of autonomic function there, sir. At present, sir, there are some laboratory tests, but they're not used extensively. For public health reasons or for whatever reasons, sir, no laboratory test is used routinely in the program. Next, please. Next, please. Sir, now how to do this? Why this continues, sir? And I was supposed to speak on the way forward, sir. So I was just saying that it is not just looking at the signs and symptoms. We need a multifactorial approach to tackle all possible causes of the disease causation and its associated morbidity. There is no mortality, but there is morbidity. Now, these circles in red, they say that, sir, the cleanliness and the good hygiene, the Swachh Bharat Abhiyan, it contributes to it, sir. In the West, in the Europe, and in the developed Western nations, sir, they got over leprosy just by the hygienic part of it. There was no dapsone, there was no MDT at all, sir. Still, the prevalence of leprosy there is zero. The incidence was very, very low. They treat it early. So the cleanliness and your personal hygiene around you, of yours, as well as of the environment, does contribute to this. I'll come to it again, sir, when we will talk about the transmission of the disease. Now, we also need, sir, in our country especially, sir, we are suffering from a lot. We need a lot of improvement in nutrition, and quite a substantial population suffers from malnutrition. Because of this malnutrition, sir, our immunity is not optimally connected to fight the disease. So by improvement of the nutrition also, we can optimize our immune system to fight the disease. Because in 95% of cases, we don't ever manifest leprosy, although the tests which are available will say that we were exposed to leprosy. So the optimum host immunity is required to overcome the disease. Then the empowerment of the society is required, sir, so that the stigma associated with the disease goes away completely. It has decreased tremendously after the introduction of MDT, after the decrease in morbidity and disabilities caused by leprosy. But still, sir, we want to continue with this because it's not only the stigma in the society. Sometimes the patient who is disabled suffers from self-stigma and passes the stigma all to his family as well as neighbors. And therefore, empowerment of the society and partnerships with the society will help to overcome this stigma. So we have to overcome the stigma, we have to improve the malnutrition, we have to have the personal hygiene, just like we are emphasizing in COVID outbreak. Especially this is the time of the COVID and everybody talks of COVID. But it definitely, the personal hygiene and environmental hygiene plays an important role in the transmission of the disease. Now tackle the disease. For tackling the disease per season, once we have taken the, it means you have to look after both the agent factors as well as the host factors. And nutrition comes in the host factors. So that's why we need a multi-pronged and a multi-channel approach to overcome the disease, and probably we will also be able to eradicate the disease. Next, please. Next, please. Yes, sir. Now, this is just to show the disease causation for the for the students who may be listening to this. The disease is, yes, susceptibility to the disease is the main, as I said, that 95% of the population does not at least manifest the disease. The nutritional, the immunological status, as well as the genetic factors contribute to the susceptibility of the disease. We'll come to them later on. But the environmental factors also play an important part. And these environmental factors control both the agent factors as well as the host system. It affects the host factors as well as the agent factors. Next, please. In leprosy, it is actually identifying it is mainly dependent on the clinical diagnosis, especially in the programs. So there is a particular clinical algorithm, that is the symptoms and signs of the disease, which are recognized by the examining doctor, and they are labeled it as leprosy and divided operationally into paucibacillary and multibacillary, depending on the number of skin lesions and the nerves involved. Normally, you should have a definitive diagnosis besides the clinical assumption. I don't say that clinically we are wrong when we identify a disease, but you still may be missing some of them, and they will be continuing to be in the environment around us and spreading the disease. So a definitive diagnosis and a laboratory-based test are required for complete confirmation of the disease, identifying the disease, giving treatment, doing surveillance, as well as saying when to stop the treatment. But there are a few steps, there are a few diagnostic steps which are there for identifying not of the agent, but of the host. By you identify the host response by seeing the lepromin response, that how the CMI, the cell-mediated immunity of the patient, it responds to the antigen that you put in as a part of M-Lepre that you put into your skin. That response is the lepromin response. This was one of the earliest response seen even when dapsone and multi-drug therapy had just come. And that time, everybody was undergoing a lepromin test to see whether the disease, they have a sufficient CMI or they don't have it. Patients, people who had sufficient CMI said that that could be a better prognosis than those would require lesser treatment, lesser number of drugs than those who were lepromin negative. Then identifying complications of the disease. Now, what the program actually says is that you identify, notify any person who reports with a type 2 reaction. Just before that, I'm sorry, I did not mention the type 1 reaction. It is believed to be regulated by the CMI response, and the type 2 reaction by the cellular or the humoral response. The type 1 reaction, they say this is not recognized in the program. They just say that there's inflammation because when the bacilli infects the skin or the nerve, there is a little inflammatory response. But in type 1 reaction, this is exaggerated. Both the skin, the lesion may become reddened, or the nerve may become thickened and tender. This needs to be recognized. This needs to be emphasized so that we can tackle the disease. Not only the disease, also the disabilities caused by the disease. Because majority of the morbidity or the disabilities caused is because of uncontrolled type 1 reaction and not adequately treated type 1 reaction. The other is the type 2 reaction, that is the ENL reaction, which there are multiple nodules all over the body and also nerve involvement. This is also there. So this is one way that patient may present as complications, and this needs to be recognized, and this is also the clinical diagnosis. Now, as I already said, epigenetics and environmental factors also influence the disease, and I'll come to it when we come to the transmission. Next, please. I was saying that we need early diagnosis of the disease. We need a laboratory test. And we also need empowerment of the public so by IEC activities so that they understand what is leprosy, so that they report to a doctor, because it is such subtle symptoms that they don't come to the doctor. And they don't report when the disease is so early and can be treated completely. There is a little stigma attached to contact tracing, but with the IEC activities, there should be no stigma at all with it, because even if you are a contact of a leprosy patient, you may or may not develop the disease. All contacts don't develop the disease, although it is more common as compared to the general population. But contact tracing is important because close contact people, they get the disease more frequently than those who are in a distant contact. Therefore, involvement and sensitization of health workers who go from house to house needs to be done, and these IC activities will take it more forward that people come to report early. So the program has taken up LCDC activities in which all contact tracing and leprosy diagnosis is done and treatment is given early so that they don't develop disease. The Sparsh campaign, they have modified the IEC activities, because earlier the IEC activities they were just showing the nerve involvement, the disabilities, the involvement of the eye and everything, just to show this is leprosy. But now the Sparsh campaign starts with Sapna. This is a young girl named Sapna who says, I can be cured. I should go and get myself tested and I should get treatment and I am completely cured. And networking of this is the most important. So that with our health system is one of the best in the world. But this needs that this connects with the PHC, CHC, the district hospital, the medical colleges, and at the national level with the program. So this networking is important so that there is active detection and early diagnosis. Some of the laboratory tests which are there but are not being used, because even the smears are not being used, they are PCR based tests from smears, which is the RLEP PCR, which is a mLepri specific gene which is there, whether you amplify it with the PCR and you detect it in smears. It is, the next slide will show you about it. In situ hybridization, even in the pathology smears, even if the bacilli is not there, because most of the time you don't find the bacilli, especially in the passibacillary. But you find, if you hybridize it and find out the antigens which are present, or parts of mLepri which are present, or live mLepri which is present, you can confirm the diagnosis and say it is there. Ultrasonography for detection of nerve involvement. Yes, we have to palpate the nerves. This is the thumb which takes a backstage. You see the skin, but you don't palpate the nerve. So that's why ultrasonography is there. It helps in detecting nerves which are just below the skin, and especially for the ulnar, median, and the tibial nerves. This helps a lot. You can detect it, and you can even monitor the disease by doing ultrasonography. For even an anti-resistance for AMR activities, antimicrobial resistance, these PCR and laboratory tests are important and they should be put in place for a way forward to overcome this disease. Next, please. This was there, which is this slide shows the in situ PCR, where fragments of bacilli as well as the antigens have been stained, and this is how it is being seen. This is in situ PCR, RLAP PCR, smear was again, it is a gene component where just by doing the smear and staining it and seeing it with you can find out, doing it, running a PCR on it, you can say that this patient, and it is much more sensitive than that of, which will come in the next slide, than that of a simple skin. SSS is the slit skin smear. Then, as I've already said, ultrasonography and molecular tests for detecting drug resistance. Next, please. This was a repetition. Next. See this, the first on the left hand side just shows you the difference between RLAP PCR and the skin smear, and it more than 70 to 80% of, including possibacillary patients, have been identified using this RLAP smears. All multibacillary patients, they have been, but even in the possibacillary, the sensitivity goes up to 70%, by which using this RLAP PCR, you can say that there is a definite test that yes, you can do it. Just like you do it in RT-PCR for COVID test. This is also a test where RLAP PCR is used, and this is can be used even at a PHC level. Then by using this real-time PCR, by finding, you can find them either in the soil, in the water, in the environment, in the tissue, saying that they, if you find the RNA RT-PCR, then it is a live bacilli. If you do it by a DNA RT-PCR, then yes, it is a dead or nearly dead bacilli. And that is how we are using this to see the transmission of leprosy and where it travels. So in some of these areas where there were many leprosy patients, you found them both in water and soil, saying that the environment, the soil and the water do contribute to the transmission of the disease, and the bacilli remains there, sometimes live and sometimes dead in the soil and water. And this is one of the way why in endemic pockets you find more leprosy patients, even who are living on the same street or using the same soil and water for their daily purposes. So this was one thing which was seen by using these PCR methods to see that transmission of leprosy, the environment was contributing to the transmission of leprosy. Next, please. Definitely there could be intermediate hosts which were also doing, but this was seen in the soil and water. Then we need better, the second part is that we need better treatment modalities. It is both curative as well as to arrest the transmission of the disease. The curative part is it should completely be symptom free and there should be no relapses and recurrences. Also, even after stoppage of therapy, there should be no complications, reactions, and disabilities. Next, please. Next, please. So that among the treatment modalities, MDT, it has definitely helped. This has helped in controlling the prevalence and incidence world over and including our country. However, better and more optimum treatment is required, especially to prevent and treat complications associated with it. Special care and treatment modalities for taking care of nerve involvement and damage. At present, we don't bother about the type 1 reaction, we don't even notify it. So that is required, that we take special care of the nerve involvement and damage. If a patient has a has a nerve thickening of a nerve, dermal nerve, or a subcutaneous nerve, or a nerve trunk, and a skin lesion associated with it, nearby it, in the feeding area, that should be taken care of, because there are more chances of nerve involvement in such patients than others. Now, clofazimine was earlier for MDT. There are two regimens, PB and MB. In the PB, you just use 2 drugs, and in the MB, 3 drugs, which includes dapsone, clofazimine, and rifampicin. Rifampicin, of course, is given once a month, but dapsone and clofazimine were daily. Now, seeing that the clofazimine was helping in reducing the reactions and decreasing the morbidity, even WHO in its recent guidelines published at the end of 2018, they have said that clofazimine should be used for paucibacillary disease as well, so that it can take care of the nerves. It remains in the body for a longer time and it continues to act even after stoppage of therapy. Now, the other part was taking care of person affected and aftercare modalities. Yes, this to some extent the program takes care of it, but self-care and training after completion of treatment is most important. Taking care of insensitive hands and feet, taking care of the trophic ulcers, and even of the disabled hands and feet is required, and this needs to be emphasized. The other thing that can be added is the immunotherapy. Dr. Shantanu will definitely be talking about the immunotherapy, but I will also touch on it because immunotherapy as an adjunct to MDT is a better treatment modality than MDT alone. Next, please. Next, please. In this, there are several drugs as well as related mycobacteria which are used as immunotherapeutic agents as an adjunct to MDT. But see, what does immunotherapy does? It attains faster smear negativity, killing of viable bacilli, clearing of dead bacilli and their products, which are supposed or at least believed by a section of leprologists to also contributing to nerve damage, reducing the incidence and severity of reactions, and preventing disabilities and nerve damage. Because even with MDT alone, even after the treatment, and you do histopathology of the skin overlying the nerve, you will find that the granuloma is still there. By using of this immunotherapy as adjunct, this granuloma completely clears. So even the dead bacilli, which may be lying in the tissue, cannot precipitate a reaction. Therefore, immunotherapy as an adjunct to MDT is better than MDT alone. This was proven in the multibacillary patients, but even in paucibacillary, it does all this. It reduces the incidence and severity of reactions, both type 1 as well as type 2. And it also, there was the next slide will be showing it, where there was return of sensation in some of these patients who got immunotherapy with MDT, that is MIP with MDT for those 6 months. Next, please. This is in the highly bacillated patients. In the left one, it just shows that the bacterial clearance is faster, viable bacilli are killed, dead bacilli are cleared, and the BI attained is faster. The first line, this is of the MIP, where the BI is attained. There is a fall in the BI much faster. And the second one, which is towards the right, although there were reactions in both the group, in this highly bacillated patient, the reaction subsided much earlier and there was no reaction after release from treatment. Next, please. The next slide will show about the paucibacillary patients. Here, if you see, this one is just showing you there is decrease in size of the lesion. So the size of the lesion in paucibacillary, there is a decrease in size of the lesion. There is decrease in the infiltration in the lesion. There is decrease in the nerve. And here this one shows that even the sensation returns was there. In a substantial number, there was return of sensation with the addition of MIP to the MDT as an adjunct therapy. Next, please. This is just showing the same thing, that here if you see, it is that in the initial part, yes, this was type 1 and this is type 2. In the initial part, yes, both of them were nearly similar, both the groups. This was a double-blind study. And after 6 months, you will see that the number of reactions have decreased tremendously and the patients have recovered completely. The reactions were less, both type 1 and type 2, in these paucibacillary patients. Next, please. This is what an immunotherapy. This is in a patient who got 2 doses. This is after 2 doses in 6 months. And you can see how all the lesions have disappeared. This is not possible with MDT alone. This is possible with immunotherapy, with MIP and MDT. Next, please. The third part would be for prevention of leprosy. So vaccines for prevention, Dr. Shambhunath will be talking much detail, but I would just enumerate. There are drugs which were used long back also. Zinc was used, levimazole, dapsone, acidapsone. They were all given as prophylactic agents. And now more commonly that we see is single dose rifampicin or multiple doses for chemoprophylaxis. But all this, but with the dapsone, acidapsone, as well as SDR, what we actually see is it is only a postponement of the manifestation of the disease. Sooner or later, the patient does manifest the disease, and the follow-up which is available is too small with such a high, long and variable incubation period. The second part which was seen with SDR was that if their patients have a BCG vaccination, this SDR, the with the prophylaxis with SDR was much better. That means you need immune therapy. You need to improve your host immunity so that the SDR also acts. But we all know very well that although BCG in our country is given at birth or given in the younger child group, still our country has about 60% of the new cases of the world. So in spite of BCG, still leprosy there. So there is something beyond BCG which is required. And for that, MIP was one of the things which can be used. Among this, MIP, it is DCGI and FDA approved. It is tried in large-scale field studies. It is safe and well accepted. It provides protection to contacts of leprosy patient as well as the general population. It is a very good instrument and also active as an adjunct immunotherapy with MDT. So it has a double role, both for immunotherapy as well as for immunoprophylaxis. Another thing which is not added here is it also protects against TB. That we had seen that the population in which we had given this vaccine for control of leprosy, TB was also much controlled in them. So it has a dual action in a country like ours, which is endemic both for TB and to some extent to leprosy. Next, please. So these are just to summarize the advantages of this. This was just saying that as an immunomodulation, this can be used as for immunotherapy as well as for vaccine. And this could also reduce the transmission dynamics because lesser number of patients, lesser transmission. So this is just to say that this could lead to so much things. And as an adjunct to MDT, there is lesser morbidity during treatment and even after release. And it prevents disability, and even QNP is quiet nerve paralysis. None of the patients who were on this suffered from quiet nerve paralysis, whereas there is a small proportion who do develop quiet nerve paralysis without any pain, just a disability, even several years after completion of treatment. So this reduction in disability would also help in reduction of the stigma. Recently, we have done the cost-effective analysis of this, which is still under publication. And so, but this is found to be very cost-effective. Next, please. So in summary, I will just like to conclude that is not just one or two things which will help. It is a multi-centric, multi-pronged approach which will help. The Swachhta Abhiyan will add to it. Reducing malnutrition will help the host in fighting out the disease. It is also seen, especially in the recent report by BCG, that universal immunization program helps in better protection by BCG, both for TB and leprosy, as well as for the other things. So a better host response would be there. Environment, the empowerment by IEC of the society at large, then they need to be told, they need to be educated, they need to be told about the signs and symptoms as well as how they can get rid of the disease. And there's no need of stigma. There won't be any disabilities. The modern day diagnostics and surveillance need to be put, just like We have done it for COVID. RT-PCR, there was only one laboratory doing RT-PCR. Now there are 1,500 laboratories doing. Even we can do it. This can be done in district hospitals also. This is all possible. So this should be done. Just like we are doing the TB NAT test for TB, why can't we do it for leprosy? If we have to fight it, we have to take it. Engaging treating leprosy patients in these campaigns helps to remove both the self stigma and the stigma of the people. And this helps to a large extent in building self-confidence. Better surveillance strategies, just like you have it for TB, you also should have it for leprosy. And preventive vaccination for vulnerable population, which of course will be taken up by the next speaker. Next, please. Ajay, just 2 more slides. I'll just finish it off. Next, please. This is just saying that even our father of the nation was very empathetic to it. And it is not, it doesn't, and we should also continue to help all the people who are suffering from leprosy. Next, please. And this is a tribute to Shri Vivekananda ji on his Jayanti, that you should not say that we have lost a battle. We'll continue to fight it, and with multi-pronged approach, we can win the battle. Next, please. And thank you very much, one and all, for being very patient to listen to me. Thanks a lot, and for the opportunity provided to me for this. Thanks a lot.
Thank you very much, madam. It was very exhaustive and very crisp, simple, and you have very nicely summarized all the aspects, including the public health perspectives and how it should go forward. So excellently you have portrayed with your vast experience in this area of work. And there must be some comments or questions. They are coming in the chat box. In the interest of time, let us go to the next.
You can pass it on to me. Sir, you can pass it on to me. I'll answer them, sir. I'll give a written reply to them.
You can also look at the chat box. If it is possible from your end, you can have a look at the chat box. The questions would be coming there, and you can keep on answering there itself. Now we have to let us move to the next speaker. I would request Professor Katos, please welcome the next speaker, Professor Datta.
Full screen.
I request my co-chairperson, Dr. V.M. Katos, to please welcome the speaker, next speaker, Professor Datta.
It's a great pleasure, Professor Datta, to welcome you to this presentation as a president of Indian Institution of Leprologists and also a very, very senior old dear colleague. You're well known for your contributions, serving the leprosy patients in the field, in the difficult areas. And your life is a story of a total dedication. Of course, as a dermatologist, your charm will be very different on the other side, but your contribution to these suffering people, they've been so enormous that it is a great pleasure to welcome you here today. And whatever you articulate about the dermatologist's perspective, their feelings, how they deal with the situation, what they should be doing, I think they will ring in their minds as a senior colleague. So it's a privilege to invite you to make your presentation. Dada.
Thank you, Dr. Kalroj, for beautiful words. I pay my respect to the great Swami Vivekananda, who was born today, and whose memory we are doing it. Can we start the slide, please? My namaskar to all of the delegates who are present over here to witness the whole program. Next slide, please. Next slide, please. Leprosy in India. Leprosy is a problem, is suffering, but you can see this old lady who has a smile on her face. So with leprosy, you can smile, which is very difficult, but we are the agents who has to bring the smile in the face of these patients. Next slide, please. So you can see on 1931, the picture of India, it was full of leprosy patients. And in the last third slide, that is March 2011, it was practically free, leprosy free. Next slide, please. Did you think leprosy is a disease of the past? The answer is a big no, because it is not rampant, but it is still there amongst people in many pockets. And from there, it may again raise its big head and affect the people of the country. Next. So leprosy makes a comeback in India, I think within a short time. Next. You can see this poster. It is an IEC activity of some NGO and the government. So this has been stuck in many places and people see. I do not know if the patients or the relatives see this and then go to seek medical advice or medical aid, but this is there. Next. Professor Kiran Kachroj has given an elaborate description of the whole of leprosy. So I think we can pass through all these pedantic knowledge. I would like to share a few experiences, that's all, with a few photographs. Next. As you know that leprosy can be viable up to 5 months in the environment, and it divides extremely slow to with than with the other bacteria, and because of its slow growth, the incubation period in human is long, and the minimum is 2 to 3 years. The average is 5 to 7 years, but there are patients who even come after 10 to 20 years. Next. So because of the long variable incubation period of the disease, our understanding of its transmission remains incomplete. The mode of transmission could occur by the exposure to nasal or oral secretion of patients harboring bacilli, or the skin-to-skin contact, or congenital transmission, or dermal inoculation via tattoo needles, etc., or contact with infected soil, which Dr. Kiran Kachroj so elaborately explained, and also maybe to the exposure to insect or arthropod vectors. Next. So the diagnosis, the clinical diagnosis of leprosy is based on finding consistent skin lesions associated with sensory loss. That is very important. And the next thing is with or without associated thickening of nerves. Nerves, it affects the nerves, but the nerves initially may not be thick, and only the supplying nerves usually become thick. And there's one type called purely neural disease without clinical evidence of skin lesions, and that is called pure primary neuritic. It is difficult to diagnose, but there are a large number of cases, maybe 1 to 16% of cases in the country. Next. No, the before one, the one before. Thank you. So classification, it's so many classifications were made. Sushruta Samhita, an Indian medical treatise written about 600 BC, is the first recognized record of 3 clinical forms of leprosy: pure neural, cutaneous with sensory loss, and cutaneous lesions with ulceration. And throughout the mid 19th century, researchers saw fit to devise idiosyncratic classification systems like the Manila classification. Then that was in 1931. In 1938, there was a Cairo classification. 1946, there was Rio de Janeiro classification. Then 1948, Havana classification. And in 1953, there was Madrid classification. And in 1954 or 56, I don't remember, we have a classification which was made in a conference in Jamshedpur, where I am at present. Next slide, please. So there are two types of classification. One more theoretical or rather uh, academic purpose, and the other one for practical purpose. In the academic side, you have this one. You can see on the left top is the borderline tuberculoid. In the middle, there is a borderline, and on the right is lepromatous. In between tuberculoid and borderline, you have borderline tuberculoid, and in between the borderline and lepromatous, there is borderline lepromatous. Now, the lepromatous side is where you get a lot of bacilli, and in tuberculoid pole, you get very little uh, bacillus. So, immunity is high in the tuberculosis side and very low in the lepromatous side. Next slide, please. Now, the World Health Organization, they have classified leprosy in 2012 for the practicality of it, because the people who go to the field, they can diagnose and they can understand and they can treat the patient. So this is the classification. Single SLPB means single lesion possibacillary, and this possibly single lesion leprosy is one skin lesion. If there's only one skin lesion, then it is said single lesion possibacillary. And then the other one is possibacillary, which is actually 2 to 5 skin lesions. And multibacillary bacillary is the one where there is more than 5 skin lesions. So for the PB, you give the PB kit, and for the MB, you give an MB kit. And the treatment becomes easy and the diagnosis is easier. Next. This is an indeterminate leprosy. You can see the face of this young, sweet looking girl, mildly hypopigmented. We do not know whether it will develop into leprosy or not. Usually, if the patient has high immunity, nothing happens and slowly it goes off. But if the patient has less immunity, it may turn into a disease, leprosy. Next, you can see this small white ring-like patch, circular patch on the right cheek of this sweet girl. This is also indeterminate, but it seems that it has become a leprosy patch. Next. This is a tubercular leprosy single patch. You can see it's very easy to detect. If you can see, you will understand. Only thing the test you have to do is the touch test, where the patient will tell whether he feels the sensation or not. If there is less sensation or no sensation, you can clinch it as tuberculoid leprosy or single lesion possibacillary. Next, another leprosy patch. In this case, this one oval type of patch. In this, there may be more than one patches if you search all over the body. And this is a clear-cut tuberculoid leprosy, TT type. There's another tuberculoid type which has a slightly lesser immunity than the primary one, the previous one, sorry, the previous one. So you can see there's a margin, and in the center of this lesion, it is slightly hypopigmented, and at the periphery, you see, is hyperpigmented. Oh, next patch, sorry. Next slide, please. So you can see this is a patch, tuberculite patch. In the center, this is hypopigmented, and in the periphery, it is slightly hyperpigmented and inflamed. Next slide, please. Sorry, some call had come inside. You can see there's a big patch and there are satellite patches on the sides. This is also tuberculoid type. You get hypopigmentation, and they have usually up to 5, but in some cases it may be more. But that doesn't matter. You can give PB or MB. Nowadays, as per World Health Guideline, you can give MDT for all now with rifampicin. You can give medicines. Next. This is a tuberculite patch which is going towards the borderline, or it may be a borderline tuberculoid patch. Why? Because you can see the periphery, it is swollen. It is swollen, but in the center, it is depressed. With this, we can diagnose this. And you can see one satellite patch at the northwestern part, small satellite patch. So it seems it's a borderline tuberculoid leprosy. Next. Another borderline tuberculoid, you can see that the type over here is tuberculoid type. There are more than 5, you can say many patches. If you look all over the body, then you'll get many patches. So this is towards the borderline. In the center, there's a borderline which you cannot diagnose because it is very transient. It either goes to the borderline tuberculoid pole or borderline lepromatous pole. Next. So that was a borderline tuberculoid, and this is a borderline lepromatous. Why? Because you see the lesions, raised lesions. Had it been very much inflamed, it can be ENL also. But this looks like a borderline lepromatous patch. Next. Another borderline lepromatous, you can see the raised lesions, multiple. This is in one limb, but it can occur, or it probably it is there in all over the body. Next. We come to the lepromatous leprosy. Look at the face. This is called leonine face. You try to find hair on the eyebrows. There's no hair. You can see the bridge of the nose depressed. The nose is wider. So this type, if you see any place, you can just not misdiagnose this case of leprosy. Now, next slide, please. You look at this face, lepromatous leprosy. Number of nodular lesion all over the body. Look at the nose, flattened. And look at the lips. Like a lion, the upper lip, you see there are small furrows, ridges type of thing. With this, you can easily diagnose this as lepromatous leprosy. Next. Look at the ears of this patient. There are multiple nodules. These nodules will tell you that it can be nothing else but lepromatous leprosy. You just see the ear, and then you see or look for the lesions in other parts of the body. You surely get lesions all over the body in this case. Next. The deformities. leprosy, when it is there, it can be cured. But when deformity comes, it is very difficult to go out of it, to come out of it rather. And there are many types of deformities, and I think Dr. Kiran Katoch has gone through it very nicely. I'll only show you a few photographs. What are the deformities? Specific deformities due to local infection with M. leprae, loss of eyebrows, nasal deformity, banana finger. I'll show you one. Paralytic deformity due to damage of local nerves, claw hand, toes or foot drop. Anesthetic deformity due to neglected injuries, ulceration, scar contractures, shortening of digits, mutilation, and trophic ulcer. So these are the things which we need to worry about, because it makes the patient maim and it makes them difficult to be with other people, because then they are marginalized because of this problems. Next. Look at the neck. You see a thick raised rope-like thing, and that is a nerve. And this you get in leprosy. You can feel it. It is usually non-tender, but it can be tender also. The nerve can be so thick. Next. There are two photographs over here, one of the arm and one of the palm. On the left, you see the arm. Just below the elbow, there's a swelling. That swelling is the ulnar nerve, which has abscess in it. So it becomes thickened. We can palpate an ulnar nerve and you can understand whether it's thick or not. But this is more thick and it needs surgical intervention. On the right, you see the finger, ring finger. Swelling is quite big. And if this swelling increase, then it becomes a banana finger. This is how a banana finger looks like, very nicely. This is the initial stage of a banana finger. Next. See, facial palsy due to thickening of nerves. So he's smiling and you can see on the right side where there is palsy, the lip cannot become wide. On the left side, it is normal. Next. Next. The starting of claw hand, you can see on the palm, a reddish area and the normal skin area. That reddish area is inflamed and is in reaction. And if you see those two, the ring and the little finger, it is more bent. The patient could have straightened the finger. If he had straightened the finger, you could have seen the curvature on the ring and the little finger. Because of this inflammation, the nerve gets more damaged and the claw hand deformity is formed. Next. Over here on the right hand, you can see the claw hand deformity. And you can see the wasting of the interosseous muscles from the back of the palm. Next. The claw hand on the ring and the little finger. You can very clearly understand this. Next. These actually go to the surgeon and the surgeon operates on them. And with this operation, they can straighten the fingers. And the deformed hand, you can see. This is why they are marginalized, because of their odd looks. What happens? Why is it deformed? The bones, they actually become brittle and are absorbed. The bones are absorbed slowly, and the fingers slowly goes down because the bones are resorbed. And that is how this deformity occurs. Next. A deformed feet. Next. And because of that deformed feet, you have trophic ulcer also. You can have trophic ulcer without a deformed feet. They are not that much deformed, but just simple ulcer. Hansen's patient can have ulcer like this. Why is this ulcer? Because when they walk, they get trauma. This is called micro trauma. The vasculature on this area is very less. And because of the continuous micro trauma, that the tissue there becomes weak. It doesn't get the blood, and the tissue, because of the trauma, gets weak. And slowly the ulcer occurs. Next. You can see the ulcers on the feet. They are usually at the pressure point where there is optimum pressure. When a person walks, he puts the heel first, and then the heel is raised and the pressure goes through the toes, exact place where the most of the pressure is there. So these are the places usually where you get the ulcer because of the micro trauma, constant micro trauma. Next. A deformed face of a leprosy patient. You can see the smile on that patient. Next. Next, please. Eyes also get involved. Because of the paralysis of the eyelid cannot come down, and that is called lagophthalmos. And because of the lagophthalmos, the retina of the eye gets bad. It gets constant injury, and you can see that it becomes hazy, and slowly blindness develops. And the patient can become blind after some time. Next. The treatment of leprosy, you can see there are two strips. One is green and one is partial brown or orange colored. So the green one is for paucibacillary and the orange color is for multibacillary. I won't go in because of the lack of time, and most of the people who are listening to this presentation know about this already. Next slide, please. So this also is known to all of you. The single dose treatment for single lesion paucibacillary, that is a single dose of rifampicin, ofloxacin, and minocycline. That's all. A single dose usually cures it. If not, you can give once a month or once in 3 months, and it goes up. Trial is on at some centers. Dr. V.V. Pai is probably doing a trial on monthly pulsating dose of 3 medicines like this, which will be supervised in the clinic only. And he's getting good result with that for all the cases. Now we come to the paucibacillary, which is less than 5 lesions. There you get rifampicin, 600 once a month, and dapsone, 100 milligram daily. And the duration, as advised by WHO, is for 6 months. For the multibacillary leprosy, which is 5 lesions and more and nerve involvement, you get rifampicin, dapsone, clofazimine, 300 once a month, and then 50 milligram daily continuously. So the duration is for 12 months. Next slide, please. Next slide. Yeah. So you can see the multibacillary regimen. It is for 12 months with rifampicin, dapsone, and clofazimine. Next slide, please. For patients who cannot tolerate the drugs, the standard MDT drug, The World Health has provided guidance for alternative MDT regimen to be administered under direct supervision in a referral center. Next. So to replace rifampicin in adult MB patients who suggested daily administration of clofazimine 50 milligram, ufloxacin 400 milligram, and minocycline 100 milligram for 6 months, followed by a daily clofazimine 500 milligram with either minocycline 100 milligram or ofloxacin 400 milligram for at least 18 months. And who patients who cannot take clofazimine can be treated with a combination of 600 milligram rifampicin, 400 milligram ufloxacin, and 100 milligram minocycline, which also is named as ROM, given once a month for 24 months. Next. Treatment of the patient, as Dr. Kiran Katoch has told, has to be multi-pronged. Medicines are needed. Along with that, other things also are needed because they become marginalized sooner or later. So we need the training, we need rehabilitation, and they need mental, physical, and in some cases, financial support. Next. Thus, the CBR or the community-based rehabilitation was there. It has come up just to help these patients. With respect to leprosy-related disability, the objective of CBR program, which started in 1995, promised to rehabilitate the cured but physically and socially handicapped leprosy patient through programs that will help them to reactivate their traditional occupation or start a new occupation or set up a small business or obtain job replacement. So when they are cured, they don't know where to go, what to do. These people, with the help of community-based rehabilitation people, they can find something to do and they can work and be in the society. Next. However, despite effective leprosy treatment, public awareness campaigns, and the integration of leprosy work into general health service, stigma is still a major issue for people affected by leprosy. Many people continue to face social exclusion and experience difficulties accessing mainstream services such as CBR programs. Example, thousands of people affected by leprosy may be in need of rehabilitation service, but only a few have access to these services. So we should look into this and try to help these patients. Next. You can see a leprosy patient who have been rehabilitated, working on a charka, making threads. Next. Next, please. So let's say namaste from the people affected with leprosy. And let's give a holistic management to our patients. Let us share my concept of life, living, and happiness. Thank you very much. Thank you all.
Thank you very much, Professor Datta. It was a very exhaustive presentation. From your experience, you have showed the snap and photographs of numerous cases, and for the youngsters, it becomes easier to really help them in clinical diagnosis or clinical suspicion, making valid clinical suspicion, and then it is very informative. And also towards the end, you have also highlighted, emphasized the importance of the community rehabilitation, which remains still today a very neglected area. It's a great program, but perhaps people will say that it has not really reached the desired goal so far as the coverage is concerned. So all of us should actually join hands to ensure that particularly people with the deformities, the privilege or the benefit of the uh, the community rehabilitation program should reach to each and every such patients who need them. With this, I must thank you and congratulate you profusely for sparing your time this evening for a noble cause here. And we all are greatly benefited with your talk. Thank you very much, sir.
Thank you.
So may I now request my co-chairperson, sir, uh,
Yeah.
Dr. Katoj, would you please welcome the next speaker, please?
Yes. Thank you, Professor Tripathi. Thank you very much. See, actually, my knowing Dr. Shambhu Samazdar has been only for less than a year. But I mean, within this year, I've developed a lot of admiration for his, his intellect. He's a emerging generation of the clinical pharmacologists who are required as a very big group. But I think he showed his intellect, organization capacity. And Professor Tripathi, this is your gift to the world of, at least the leprology and for the science also that you're building him up. My privilege to invite Dr. Shambhu Samazdar to deliver on the MIP vaccine, which I think he did very eloquently last time. But I think he would have you'll add a new flavor because that brings, that another, this is one again a pride of India, a product of India, which has reached in so many corners. And so is Dr. Shambhu Samazdar to deliberate on that. Yes.
Thank you, sir. Thank you for your kind words, sir. So it is a really honor for me to being with all of you, like Professor Katoj, Professor Tripathi sir, Professor Rotindranath Dotto sir, and Professor Kiran Katoj sir, madam. So today, for next 10 minutes, I am going to discuss on MIP vaccine. Please change the slide. Next slide. So in late 1970s, Professor Talwar had identified Mycobacterium W from a group of 16 strains of atypical mycobacteria, which generally give a highest immune response against Mycobacterium leprae. And that time the nomenclature was MW, as it was an outcome of the coding that given to that atypical strains of mycobacteria that has been investigated for the development of vaccine against leprosy. So later it was found that there is some hypervirulent Mycobacterium tuberculosis W strain that was from a Beijing genotype family. So they named that as MW. So there is a need to change the name of that MW. And at that time, it was renamed. The Mycobacterium W was renamed. And what is that? That the new name becomes that Mycobacterium indicus prani. And this name generally given on the basis of the location of its isolation from India. And we all know that this vaccine is also in our Indian vaccine, indigenous vaccine. And then the pran, that means that now the name pran came from the name of Professor G.P. Talwar, that is Professor G. Pran Talwar. So that pran came from that. And another institute where it was generally obtained, that is the National Institute of Immunology. So that is generally comes under pran E. So ultimately you can see in these slides how the Indian national flag and the great man Professor G.P. Talwar and the National Institute of Immunology in Delhi. So this is the origin of that particular name of Mycobacterium indicus prani. Next. So MIP vaccines, generally the Ministry of Health, Government of India has taken on 7th May 2017 to launch an immunization project to eradicate leprosy from India. And for that, they took this new vaccine, MIP vaccine. And it is important to note that the new cases all around world, if we can see the data from 2015, that 60% of the global cases are from India. So this is why we have to give emphasis on this disease, leprosy, and we have to find something beyond what we have now. So that is why the vaccine has a very specific place. And this MIP vaccine generally based on a autoclaved of that particular bacteria, Mycobacterium indicus prani, and they are recommending it in addition to drugs for treatment of leprosy patients. This is also in the program that the family members and the immediate contacts of patients, they also will be immunized with 2 doses of vaccine at 6 months interval. Next. So generally we can say this as a immunotherapeutic cum immunoprophylactic vaccine. So what happened? Generally the immune deficit is primarily due to the inability to react against Mycobacterium leprae. So the lymphocytes do not undergo the blast transformation in presence of Mycobacterium leprae and do not generate the cytokines that influence the macrophages to permit or not permit the multiplication of the ingested Mycobacterium leprae. So this is the mechanism, this is the defect in leprosy, and for development of vaccine against leprosy, they had adopted a heterologous approach, as the very nature of this immune deficit is generally due to that inability of the susceptible individuals to react Mycobacterium leprae. So they are using, if they use just Mycobacterium leprae as the basis of vaccine, that will become something illogical. So they had collected 16 strains of different atypical mycobacteria. Among them, many were non-pathogenic, and all of them were generally cultivable in vitro. And each one of them was investigated for its ability to cause that blast transformation of lymphocytes. And that generally can help the lepromatous leprosy patients. So there are generally in broadly the 5 strains of mycobacteria was identified, but among them the Mycobacterium W, or which name was become Mycobacterium indicus prani, that was shortlisted for possessing the requisite capability. Next. So there are some additional property, or we can say extra leprosy property of MIP vaccine. So generally this MIP shares antigens with not only to that Mycobacterium leprae, but also the Mycobacterium tuberculosis. And it has been employed successfully in treatment of category 2 difficult to treat tuberculosis patients. Apart from that, this is a potent invigorator, we can say, of both cellular and humoral immune response, and it can be sometimes, it was thought, or sometimes in trial mode it was tested as an adjuvant in our birth control vaccine that was generally against the human chorionic gonadotropin hormone, where its inclusion generally enhances the antibody titers substantially. Apart from that, there is some definite evidence that it can clear the ugly anogenital warts and lesions elsewhere on the body if they can be given intralesionally. And there is lots of case reports that MIP can clear dramatically anogenital warts. And we are fortunate that as I am now attached with School of Tropical Medicine, the adjacent to medical college, Professor Niloy Das, who is a dermatologist from medical college, he had done some works on this aspect by clearing that using intralesionally MIP and cleared the anogenital warts. Apart from that, there are some preventive and therapeutic action on some cancer model. Specifically, there is one cancer model that is SP2 by O myeloma models. So in that also it has been seen that MIP can used as a preventive or therapeutic option in those mice, and it shows some promises. So we can assume the extra leprosy effect of MIP. Next slide, please. So if you just go by the different therapeutic indication, so it is obvious that it is approved as Kiran Katoj madam told, that it is approved by our DCGI and also USFDA, specifically for the leprosy patients who are lepromin negative. And we all know about this as immunotherapeutic agent in some other aspects also. So generally, already we had mentioned that this MIP is a non-pathogenic, cultivable Mycobacterium species, which is now widely used as a vaccine for different other diseases also, though in a trial mode. But how this action, I just want to mention one important point of this mechanism of action of these vaccines from the immunological perspective, that they generally induce the CD4 T helper cells 1. We all generally know about that Th1 cells, which is generally responsible to release different cytokines like interleukin 2, interleukin 12, 15, and interferon gamma. Therefore, there will be a promotion of cell-mediated immunity, and it has been used in leprosy patients. It is approved for leprosy patients, and now already we had discussed about that immunization program for leprosy patients. Apart from that, there are lots of trials are ongoing, specifically in tuberculosis, in HIV infection, and also lung cancer patient. So there is another indication of this particular vaccine, that is generally as a immunomodulator action in managing the non-small cell lung cancer. And there are some trial that generally if we give this vaccine to non-small cell lung cancer patients, add on to whatever chemotherapy and radiotherapy the patients are ongoing, there is a good adaptation to the radiotherapy and chemotherapy in those groups who are taking the MIP vaccine. Apart from that, the quality of life also improved. So this can be thought or considered to be used in non-small cell lung cancer patients. Apart from that, the brand name of this MIP, which is generally promoted by one pharmaceutical industry, Cadila, that is Sepsivac, they generally also promote it, or we can say the DCGI also approved that indication of this MIP vaccine as an immunomodulator in sepsis patients. So there are some randomized control trials done in sepsis patients that shows more than 10% absolute reduction and more than 50%, almost 60% relative risk reduction in mortality. So apart from that, the SafeCVac shows reduction in the days of ventilator, ICU stay, hospital stay, incidence of we can say the secondary infections, and days on vasopressor therapy. Also, it reduces SOFA score. So that is why this is another indication in is the gram-negative sepsis as an adjuvant to the standard of care. Next. So MIP also as an adjunct to the standard multi-drug regimen, it generally accelerates the bacterial clearance and shortens the recovery periods. It clears granulomas, clears bacilli that is generally resident in the peripheral nerve that ultimately restore the normal sensitivity. Next. So this is an important, very interesting paper, a research work that is published in Nature, and we are very much privileged that one of the noted researcher in this particular research work, Professor Kiran Katoj, is also with us today. So this generally suggests, or we can say it generally gives some important notes that why MIP can be beneficial in category 2 TB patients. I am not going in details to this particular study, so we can find it in net, this particular study, and this very important study, and we may ask later from Katoj madam about the results of these studies. Next. So there is some other routes of this vaccine that is from the intranasal route, if they can use MIP intranasal. So how it generally improves the outcome of the Mycobacterium tuberculosis patient. So this study generally helps us to understand how this MIP vaccine helps to recruit T cells, and that regulation of one axis known as CXCR3 CXCL11 axis. So that axis generally gives us some important clue that this vaccine can be beneficial in COVID-19 patients also. So next slide. So there are some RCTs are ongoing with MIP vaccine in critically ill COVID-19 patients. Apart from that, this vaccine is also being used, how it can prevent COVID-19 infection or reduce the severity of the COVID-19. So this is now ongoing. Trial reports are not available, but main purpose of this trial, specific trial, what I am just showing in the screen, that to evaluate that innate memory natural killer cell response to MIP vaccine. So there is hypothesis that MIP vaccine can generate or instigate the innate memory of natural killer cells. So this is a very important thing, and again we would be proud if this trial become successful. So this is what I am going to present in a nutshell. Next slide. So I had removed many slides as Madam Katoj Madam, Kiran Katoj Madam had described beautifully about this particular vaccine in her presentation before. So, and it is always a great privilege to hear from the horse's mouth, because she was so much close with different clinical trials with MIP vaccines and different studies with MIP vaccine. So thank you all again. Thank you to iNovocare and Mr. Rohan Tripathi for giving me this opportunity to sit in with all these legends in the field of leprosy. And in this occasion of Swami Vivekananda Jayanti, who had told Jivo Gane Jivo Puja. So, or we can say in every human beings, the God that is the residence of God, and how to generally offer prayers to God. It is important to serve human beings or mankind. So this is one place, this is one disease which generally taught how to generally give our prayers or offerings to patients to uphold their physical, mental, social, and spiritual well-being. So thank you once again. Over to you, respected chairperson, sir.
Thank you very much, Dr. Shambhu. And you have done justice to the topic. In fact, you have also gone to describe the all other indications, not just limited to leprosy, but rather as a product, MIP vaccine. What is its? What are the promises, and what are the other areas it is being investigated, including the COVID-19. So you have actually captured the state-of-the-art knowledge about this particular important vaccine, which has been invented and developed indigenously. All our gratitude to and thanks to Dr. Talwar. On the last occasion, we were fortunate to have him amongst us. So you have done a great job. Thank you very much. So I now leave it to my senior co-chairperson, Dr. Katoch, to say the concluding words, because it is quite a long session. And of course, there are many other areas that needs to be discussed, but then Dr. Katoch can have the concluding remarks, and I think we can call it a day. It was great experience to be amongst all of you. And what could be a better way of remembering Swamiji? Thank you very much. Dr. Katoch, please.
Thank you, Pastor Tripathi. I think first we must thank everybody who joined us today this evening. It's really a lively session in the terms of looking at the total panorama of the leprosy world, the problems which we have still faced. You see, the problems are still to be solved on the clinical front. There can be very, very bad pictures even today present in some areas where the people are ignored. But there are positive pictures also at the same time. So there, right from the what Pastor Datta described, a very panoramic view of the clinical manifestations, some of the past, some even continue to be there even when the people are ignored, their treatment is delayed. So that still continues to happen. It should not have happened, but it does continue to happen. And then the challenge is ahead, the challenge is ahead in terms of finally looking at the disease when it is treated by the people who may not understand leprosy, but they should have the tools to address that. They should have the tools to connectivity to the specialists, dermatologists, other specialists wherever they require. But ultimately, that is to be revived back. And then there are, the other things to do, like the immunotherapy, which has been there for the last more than 50 years, but it came up, went down, and now it tells, it's still required actually. It's required not only for leprosy, it's required for TB, it's required for so many indications which Dr. Shambhu Samazdar, he talked about. And there is our vaccine, which does this so many tricks, right from the gram-negative sepsis to leprosy, actually. So I think a very lively session from that perspective of, the looking at the leprosy from the clinical aspect, leprosy looking at a public health issue, leprosy looking at an environmental health issue, like what Dr. Kiran talked about. But leprosy basically a very big clinical challenge. Even today, when the teaching has become, I think, not so good, at the medical college level. So I think big challenge to the people like Professor Datta, even if people retire from the active job, but you have a lot more things to be done. The same big challenge for the senior generation who participated this evening. It's very nice, the people participated from the good institutions like Jalma also. And I think that the people from Mumbai, the people I think from other places, Hyderabad, Dr. Narasimha Rao I could see, and his remarks I could see. So I saw Dr. Dogra also entering in. Then Dr. Revankar was there. He's actually he's made the maximum comments on everything, which shows the very vibrancy of his mind. I saw vibrancy 40 years back. That vibrancy is still intact. So I think there's a senior generation who participated today. There was a job to still share their experiences with the coming leaders, and then the coming leaders have a responsibility to build the scene around. So I think great day to pay tribute to Swami Vivekananda. I said, who epitomizes the best of what the Indian thinkers have achieved over the pages. And Dr. Tripathi, of course, we need the connecting links with the people who we lost the links. Actually, people like you who link us to the science of the development, the drug development, the drug uses, and also the science where the clinical things become dominant, like leprosy. So thanks, Dr. Tripathi. Of course, the final words may come from you, actually, if you want to say, because that's ultimately this is what you organized. And you had some vision for the evening. And for the people, I said about those 50 people who joined and stayed till the last. We appreciate that there are still people to join the fight against leprosy. Yes.
Thank you very much, Dr. Katos. And I take this opportunity to also thank Madam Mridula Save, because she actually also made it possible that a good number of very senior, dedicated doctors associated with leprosy care, leprosy research, they could make it. They have participated, as Dr. Katos has also referred to a number of them. So our tribute to all of them. We congratulate you, sir, madams, that you have taken your time and spent the evening with us. And we look forward to your support in our combined fight against leprosy, and provide appropriate care to people who are suffering from leprosy. And finally, before we close, taking cue from what Dr. Katos has mentioned about apparent neglect in the education in undergraduate level as a disease, leprosy as a disease. So can I expect that from the society, if a module is created, okay, so an integrated module, okay, starting from the you can say the ethics of leprosy care, to the hard science of leprosy, pathology, immunology, the prospect of chemotherapy and immunotherapy, where does it stand now? So it will be kind of a combined module, which can be created by the society itself, the association IAL, and we can think of having a dialogue with the NMC